Hey there, and welcome back to another deep dive. Today we're plunging into a topic that carries, well, a unique weight, and often, a certain mystique: gunshot injuries. When you start exploring this area, you quickly discover that these complex wounds can feel pretty daunting, you know, whether you're a seasoned clinician or just starting out. Our goal today is basically to peel back that mystique and bring some clarity.
Exactly. Gunshot wounds, or GSWs as we often call them, are really a cornerstone of oral and maxillofacial surgery. That's the specialty dealing with the mouth, jaws, face, that sort of thing. And actually, the way we've learned to manage them has driven a lot of modern surgical advancements. So, our mission in this deep dive is to guide you through the latest understanding, maybe dismantle some persistent myths, and really highlight the incredible evolution in treating these unique wounds.
Absolutely. And we're working with some really powerful source material today, primarily a comprehensive chapter on gunshot injuries by John D. Holmes, who's a DMD, MD, and FACS. So, you know, we're going straight to the experts. If you're ready to get informed and maybe uncover some surprising facts, let's dive in. Okay, so to really grasp where we are now in treating GSWs, we kind of need to understand their origins, right? How did the introduction of gunpowder just completely reshape medicine?
Yeah, it's a fascinating journey. When Chinese gunpowder reached Europe, maybe around the 13th century, it didn't just change warfare, it fundamentally altered surgery. Before then, surgeons were mostly dealing with injuries from blunt objects or, blades, swords, knives. Suddenly, they faced blast and projectile wounds that were just completely different. And what's really striking is how early practitioners even mistakenly thought infections were caused by the gunpowder itself, not, bacteria.
That's incredible. I mean, it really highlights how new and perplexing these injuries must have been. And it sounds like surgical knowledge basically had to evolve right alongside firearm technology.
Precisely. The evolution of surgical techniques really did mirror the development of firearms. You had military surgeons like the famous Ambroise Paré back in the 1500s who were just instrumental in elevating surgery, largely through their work on battlefields. And the lessons learned there in those extreme environments, they continue to inform and improve our understanding and management today, even for the increasing number of civilian gunshot injuries we unfortunately see.
Right. So beyond that historical context, what do the modern statistics tell us? What's the true scope and sort of human cost?
Well, the numbers, they paint a very clear picture. Gunshot wounds are second only to motor vehicle accidents as a source of injury and death. That makes them the eighth leading cause of death in the United States. And while we have seen a bit of a decline in firearm-related deaths among children and adolescents, it's really crucial to remember that most reports probably underestimate the overall numbers, just because surveillance is, well, difficult.
That's a sobering thought. And when we look at the demographics, who is most affected?
The data is pretty telling. Most victims are young males, typically under 38. And it might surprise you to learn that suicides and assaults vastly outnumber unintentional or accidental shootings. Firearms are involved in, I think it's 58% of male suicides and 37% of female suicides. But here's a really critical insight for you. The number of patients who survive a firearm injury and need treatment actually outnumbers fatalities by about 5 to 1.
Wow. A 5-to-1 survival ratio. That's staggering. And it instantly shifts the perspective, doesn't it? From just fatalities to this huge burden on the healthcare system. So what does that mean in terms of like the financial cost?
It means a significant economic impact, yeah. Gunshot injuries cost the U.S. economy roughly $2.3 billion a year to treat, and taxpayers end up shouldering about $1.1 billion of that. If you zoom out, these costs are particularly impactful because the group most affected, these younger, healthier individuals, they wouldn't normally require much medical care, right? And these aren't just the immediate ER costs. They often involve long-term rehab, multiple reconstructive surgeries, sometimes over many years.
It's also striking when you consider the broader social context. Our sources indicate that while there seems to be a link between household firearm ownership and homicide rates, you need other social factors to fully explain why the U.S. numbers are so much higher than other developed countries. I mean, apparently in some nations where firearm ownership is actually required for militia duty, the per capita injuries are lower than here. It really underscores the complexity. It's not just one thing. Okay, let's shift gears a bit from the human cost to the physics of these wounds, ballistics. This is the science of projectile motion, and it sounds essential for surgeons to understand how different firearms actually cause injury.
Oh, absolutely. Knowing the weapon and the bullet type helps them anticipate problems. Things like hidden areas of devitalized tissue that might not be obvious right away. Ballistics is typically broken down into three phases. There's
Mm.
internal, that's everything from ignition to the bullet leaving the barrel, then external, the bullet flying through the air, and terminal, that's the impact on the target. For surgeons, terminal ballistics is definitely the most crucial part, but it's also where a lot of myths about wounding and, stopping power come from.
Right. And traditionally, kinetic energy, that KE gives us MV all-Vought formula, has been the sort of go-to explanation, yeah. With velocity seen as way more important than mass. Like you need about 50 meters per second to break skin, 65 to break bone, that sort of thing.
Exactly. But here's where we really start debunking some long-held beliefs. What our sources, especially this pivotal review by Fackler, reveal is pretty eye-opening. This long-standing idolatry of velocity, as he calls it, and the really sensationalized effects of temporary cavitation, they're largely myths. The human body is just far more complex. It's heterogeneous. Different tissues have different densities, different elasticities. Simple physics formulas just aren't enough to explain all of the nuances.
Okay, so if it's not just about kinetic energy, how does a bullet actually wound the body? What are the real components of the injury?
Well, the science points to four key ways a bullet causes damage. First, you've got penetration. The bullet has to go deep enough to hit something vital, but surprisingly, over-penetration, like if it goes clean through non-vital tissue, might cause very little harm.
Okay. What
Then
else?
there's the permanent cavity. This is the actual hole, the direct tissue disruption and destruction caused by the bullet's path. This is consistently seen as the most important factor in actual wounding and any real stopping power.
Got it. Permanent cavity. What's third?
Third is the temporary cavity. This is the stretching of elastic tissues as the projectile sort of pushes through. Now, its effects have often been wildly exaggerated in the past, but some tissues can be irreversibly damaged. Think about arteries forming pseudoaneurysms, these weak, balloon-like bulges. Or maybe nerves just failing to recover. But those massive zones of dead tissue, necrotic tissue that people used to think developed from temporary cavitation, they just don't really exist like that in reality.
Interesting. So it's more localized damage from the stretch, not widespread death?
Generally, yes. And finally, number four is fragmentation. This can be the projectile itself breaking apart. High-velocity rifle rounds are notorious for this, causing devastating fragmentation. Or it could be secondary fragments, bits of bone, clothing, whatever gets driven into the wound. Fragmentation from handguns, though, is generally pretty unreliable because of the lower velocities.
So if we boil it down, the most critical factors are really penetration and the size of that permanent hole it leaves behind. Which means, as Fackler points out, the energy from a typical 9mm pistol round is kind of like getting hit with a baseball.
Roughly, yes. In terms of energy delivered, it really reinforces that principle many surgeons adopt. Treat the wound, not the weapon. It shifts the focus from, guessing about ballistics to what you can actually see and assess in the patient.
Right, that makes sense. Understanding the specific types of firearms must also help paint a clearer picture then. We generally classify them as handguns, rifles, shotguns.
That's right. Handguns are typically low to medium velocity. They usually cause damage just along the bullet's direct path. Rifles, though, they can range from low to very high velocity, and they can cause much more extensive trauma.
And shotguns are different again.
Oh yeah, shotguns are quite distinct. They're smooth-bore weapons, meaning no rifling inside the barrel. They fire shells that contain multiple lead pellets, that's the shot, or sometimes just a single solid slug. And their size is referred to by gauge, which is actually a really interesting Old English measurement. It tells you how many lead balls each the diameter of the barrel would equal 1 pound. So kind of counterintuitively, a higher gauge number means a smaller barrel. And let me tell you, close-range shotgun injuries, especially with larger buckshot, they are incredibly devastating. You can even find the wadding from the shell packed deep inside the wound.
Wow. And what about the bullets themselves? You mentioned rifling.
Right, most handguns and rifles have rifling. These are spiral grooves inside the barrel that spin the bullet. That spin keeps it stable and accurate over longer distances, kind of like throwing a spiral with a football. And projectiles themselves have evolved massively over time, from simple lead balls to more aerodynamic shapes like the mini ball, and now to really sophisticated modern designs.
You hear about different types, like full metal jacket or hollow points.
Exactly. Military rounds, for instance, are restricted by the Hague Convention. That's an international agreement on warfare rules. They have to be full metal jackets, meaning the lead core is totally enclosed in harder metal. The idea is to prevent it from deforming or fragmenting inside the body, aiming for a, cleaner wound, if you can call it that. But for hunting, you have soft point bullets. They're designed to do the opposite, expose the lead tip to encourage expansion for maximum tissue damage.
And handgun bullets.
Well, because of their lower velocity, handgun bullets often struggle to expand reliably. Manufacturers try with designs like hollow points, which have that cavity in the tip to promote expansion, or plus P ammo, which is loaded to higher pressure for more speed. But it does raise an important question, right? How much of this is real wounding science versus clever marketing? And it's really crucial to remember that so-called non-lethal projectiles, things like wooden bullets, rubber bullets, beanbag rounds used in crowd control, they can still cause significant tissue damage and sometimes even death. They're definitely not harmless.
Okay, so when it comes to actually classifying these wounds for treatment, you'd think it would be straightforward. We have systems for other kinds of trauma.
Yeah, you would think. But military classification schemes often don't translate well to civilian trauma centers. Ammunition is different, the weapon power, the treatment goals. It's just not comparable in many ways.
So just classifying by velocity doesn't work either.
No, attempts to do that have also fallen short. Velocity turns out to be less critical than the bullet type, its mass, the distance to the target, and most importantly, which specific vital organs got hit, especially since most civilian injuries are from those lower or medium velocity weapons anyway. The International Committee of the Red Cross, for example, they focus purely on wound severity, how much tissue damage, which anatomical structures are involved, and they deliberately ignore the weapon type.
Which means ultimately just sticking rigidly to a treatment algorithm based on some classification that could lead to mismanagement.
It absolutely could. The clinical assessment of the wound itself right there in front of you remains the most reliable and, frankly, adaptive way to figure out the best treatment approach.
Okay, let's turn to that now, the actual management of these complex injuries. When a patient arrives, standard trauma protocols, like ATLS, are obviously essential.
Absolutely critical. And you always have to be alert for multiple injuries. A really disturbing facial wound can easily distract the medical team from something more subtle but potentially lethal, like a penetrating chest wound. Our sources say around 17% of patients with a facial GSW have associated brain injuries, about 8% have cervical spine injuries, and 13% have eye injuries. So you have to look everywhere.
And what's the biggest immediate threat with facial wounds?
In an isolated facial GSW, the single most likely cause of death is losing the airway. Simple as that. Surgeons have to have a very low threshold for establishing a definitive airway, whether that's intubation or a surgical airway, like a tracheostomy, especially with mandible, jawbone injuries. As our sources put it, and it's a powerful quote, "It is rare to regret having performed a tracheostomy, but tragic to regret not performing one."
That's a stark reminder. What about bleeding? Hemorrhage?
Interestingly, life-threatening hemorrhage is actually unusual in typical civilian GSWs from lower-velocity handguns. But high-velocity weapons or significant bone fractures, yeah, they can definitely lead to major blood loss. Initial control is usually direct pressure, packing the wound. But here's a really crucial point for you. Blind clamping in the ER, just sticking a clamp in, hoping to grab a bleeder, should always be avoided. The risk of damaging nerves and other vessels is just too high.
Okay. And you mentioned neck injuries earlier. How are those approached?
Right. Penetrating neck injuries are often discussed using zones to help guide assessment and treatment. It's a useful framework. Zone 1 is low down. From the collarbones up to the cricoid cartilage, the bottom of the voice box. It contains major vessels, trachea, esophagus, high mortality risk, hard to get direct pressure. Zone 2 is the middle part, from the cricoid up to the angle of the jaw. This is the most common site, and injuries here are often more accessible for surgical exploration. Zone 3 is high up, from the angle of the jaw to the base of the skull. Critical vessels and nerves here, and injuries are rarely fixable with direct surgery. Angiography is usually needed.
And angiography is the gold standard for checking blood vessels.
It is, yeah, for diagnosing vascular injuries. Though non-invasive techniques like CT angiography and ultrasound are getting much better and are used a lot for screening now.
Okay, moving into the operating room itself, you mentioned surgical approaches have evolved.
Yeah.
The old way was phased.
That's right. Surgical dogma used to be all about a phased approach, clean the wound, wait, maybe do secondary reconstruction later, delayed closure. But that's significantly changed.
So why the shift? What allowed for earlier repair?
A huge advance was applying rigid fixation principles successfully. Basically, using metal plates and screws to stabilize broken bone segments early on. This does a few key things. It prevents contaminated oral fluids from seeping into deeper tissues. It allows the bone to heal directly, primary healing, and it really minimizes scar contraction later. So for most civilian low-velocity GSWs now, early definitive repair is the preferred approach. Oh, and it's vital to remember projectiles are not sterile. It's a common myth that the heat sterilizes the bullet. It doesn't. So prophylactic broad-spectrum antibiotics and a tetanus shot are always given.
Right. And what about actually removing the bullet or fragments? Hollywood loves that scene.
Yeah, they do. But in reality, removing them is rarely indicated. The risk of causing more damage trying to get it out often outweighs any benefit. Lead toxicity from retained fragments is also pretty rare. But here's an important practical point you might not think about. Those bullet fragments, they're potential evidence. Hospitals have procedures, a chain of custody, often involving law enforcement, to handle these fragments properly for investigations.
That's fascinating. What about bone grafting? Has that changed too?
Big time. The old dogma was strictly against early bone grafting. You had to wait for the soft tissues to fully heal first. But current practice, especially for the midface and the cranium, actually advocates for early bone grafting. The idea is to stabilize things, support the soft tissues, reduce scar contracture, and it's showing really uniform success. For the mandible, the lower jaw, though, most surgeons still recommend waiting delayed grafting for large defects. The risk of the graft getting exposed or failing is just higher there.
Makes sense. And finally, the late reconstruction. That can still be pretty extensive.
Oh, absolutely. It can require multiple surgeries over time. And for patients with self-inflicted GSWs, there's even a complex sort of ethical debate about delaying versus immediate reconstruction, partly because of the sad reality of recidivism rates for suicide attempts. It adds another layer of complexity.
Wow. Okay, that was a truly immersive deep dive into gunshot injuries, from their ancient origins with gunpowder through the intricate, often misunderstood science of ballistics, and right up to these evolving surgical techniques. It's just abundantly clear this is a field demanding constant learning and adaptation.
Absolutely. That ongoing evolution, driven by lessons from both military conflict and civilian trauma, it just underscores this constant push to improve patient outcomes. Advances like better imaging and those rigid fixation techniques we talked about, they've fundamentally shifted things towards earlier repair and, importantly, a much greater focus on the patient's long-term quality of life, not just, immediate survival.
So what does this all mean for the future then? Given how dynamic both weaponry and medical science are, what might the next big paradigm shift look like in GSW management? And how will surgeons keep balancing that immediate life-saving need with the really intricate demands of long-term rehab and restoring quality of life? It's a complex, vital question. Certainly gives you something to mull over. Thank you so much for joining us on this deep dive. We really hope you're leaving with a clearer, maybe more nuanced understanding of this incredibly complex topic. Until next time, keep that curiosity alive